All right, let's run through the Third American Society of Regional Anesthesia and Pain Medicine Practice Advisory on Local Anesthetic Systemic Toxicity. This is a problem that as clinicians we potentially could face, and it's important to be able to recognize its very diverse presentation and effectively treat to prevent severe toxidrome. So you can really prevent progression of the toxidrome if you know what to do early. Local anesthetic systemic toxicity is defined as cardiac and CNS toxicity consequent to unintended intravascular injection or delayed tissue uptake of local anesthetics. I want you to refer back to this flow chart to work through treatment. This is available on Azure's website as well as within the guideline. So contributing factors, we have patient risk factors, concurrent medications, the location of the block. Some blocks have faster absorption, the type of local anesthetic, the total dose, which is your concentration of the local anesthetic times the volume. Timeliness of detection, picking it up early and getting intralipid in can really prevent the negative inotropy, negative chronotropy, the negative CNS symptoms that can occur, and adequacy of treatment. So what is a practice advisory? Well, it's not a standard of care. So as you know, when we start an anesthetic, we have standard of care with our monitoring. For example, EKG, blood pressure, pulse oximetry, monitor respiration, usually with Untitled CO2, monitor temperature if temperature is likely to change, and we are present throughout the entire anesthetic. That's a standard of care. If you deviate from that, you're considered negligent. So you get on the stand in a court trial and a juror of your peers says you were negligent. It's not something you ever want to hear. But as practice guideline is really a best practice. It's a group of experts review all available trials and come up with a best practice. And it should never be superseded by your sound medical judgment. We have to remember that case reports might be biased towards positive outcomes. For example, if we have an incidental intravascular injection where a patient has cardiac arrest and we do prolonged CPR, give intralipid, and get the patient back, and they go home to have a normal life, we're going to want to report that case. But someone has a case with a poor outcome, they may sweep it under the rug, and it won't be reported in the literature as much. So keep that in mind when you read your case reports. Local anesthesia, a long time ago came out, but very early on they recognized toxicity. And even when the less cardiotoxic enantiomers came out, they still had serious morbidity. And then eventually they started working with the intralipid, and here we are today. So toxicity is multifactorial, binding of inhibition of the sodium channels, and the inhibition follows the order similar to potency. Think of lidocaine, 2% versus bupivacaine, 0.5%. Equally effective in the different doses, but the bupivacaine is more potent as you need less drug to get the same effect. Potent local anesthetics inhibit components of oxidative phosphorylation. So not only do we have accumulation of fatty acids in the cytoplasm, we also have a lack of the ability to get those fatty acids into the mitochondria to have oxidative phosphorylation. And so that's why we see our symptoms in organs less tolerant to anaerobic metabolism, such as the heart and the brain. Little demonstration of free bupivacaine becomes tissue bound, inhibits this enzyme, which causes accumulation of cytoplasmic fatty acids, prevents the translocation into the mitochondria. So we have an impaired energy deficit that decreases our cardiac output, as well as the accumulation of fatty acids causing arrhythmias. Now we give our lipid, and the lipid will bind up the free bupivacaine and shuttle it away from the brain and the heart. Why does it do that? Well, think about alpha half-lives. So when we have our heart pumping, it brings the blood to our vessel-rich group, our brain, our heart, lung, liver, kidneys, uterus. And then as cardiac output keeps going round and round, it distributes to the vessel medium-rich group, which is our muscle. So as the lipid binds up your bupivacaine and then washes out of your vessel-rich group into your vessel medium-rich group, we will halt the toxidrome. And just to note, we also have a vessel poor group, which is our bone and fat. So we talk about the alpha half-life of a drug. Think Propofol. We inject Propofol, we fall asleep because of the GABAergic effect on the brain. As the heart keeps pumping, it brings that concentration below a therapeutic effective level and go to the muscle, and you wake up. Has nothing to do with hepatic or other types of metabolism. It is purely redistribution, and that's called the alpha half-life of a drug. Here's a schematic of intralipid binding up your bupivacaine and shuttling it away from the vessel-rich group to the vessel-medium-rich group. Not so much going to be asked on your boards as far as the ratio, but just a concept that I think helps you understand how these toxicities present. So we have our CV to CNS ratio. The dose it takes to cause cardiovascular effects versus the dose it takes to cause CNS effects. So we're going to have a low number with a drug like bupivacaine. In other words, bupivacaine takes a very large amount before you seize, which is going to give you a lower quotient. So bupivacaine toxicity may present with central nervous system signs, but it also may just present with arrhythmia. And that's because its CV to CNS ratio is low. Versus lidocaine, I'm injecting lidocaine and all of a sudden the patient seizes. Well, guess what? I'm going to stop injecting. And that's a good thing, because they seized and they warned me not to keep injecting before I had cardiotoxicity and death. So as long as I manage the seizure okay, patient might be okay. So the CV to CNS ratio predicts how they're going to present. So how do we prevent last? Well, there's no single elimination technique, but we really want to have vigilance. So we want to see the tip of our needle, and as we inject, we want to see the spread of local in the field. So if we look at our ultrasound screen, we want to see the local spread. If the local is spreading on the field, it's most likely not going in a vein or an artery. We want to frequently aspirate every 3 to 5 mLs. When we aspirate, we don't want to aspirate too hard because that can cause compression of the vein. We want to let up on the probe as we aspirate to make sure we're not compressing a vein, which has been written up several times in the axillary block literature. If an intravascular dose does occur, it should contain the lowest possible dose of local anesthetic. So that means there's no reason to use 0.5% ropivacaine or bupivacaine if you don't need motor block. So you may want to, say, take 15 mLs of 0.5% local anesthetic and add 5 mLs of preservative-free saline to make a 0.375% solution. Or maybe you can go down to 0.25%. Or if you're doing a continuous infusion, go down to 0.125%. And then you can take epinephrine and use it as a test dose. So 5 micrograms per ml of epinephrine is considered 1 to 200,000 concentration. You can add that to a block, i.e. 100 micrograms of epinephrine to a 20 ml syringe of local, and that will be 5 micrograms per ml of local anesthesia, of epinephrine in local anesthesia. This will decrease the uptake of the drug, keep serum plasma levels low, and also act as an intravascular marker for intravascular injection. I personally don't do this in my practice, as I try not to put epinephrine around the nerve to not take away blood flow from the nerve to minimize risk, although it is a very acceptable practice. Again, we want the lowest total volume and the lowest total concentration. When I was a resident, it was common to put 30 mLs of local anesthesia for an interscalene block, but with the advent of ultrasound, needle placement perinaturally, speakers like Admir Hazik out of NY SORA would recommend maybe 14 to 17 mLs for an interscalene block. Now you could use very, very low volumes like 3 mLs and the block will work, but it will wear off very quickly. So we have to find the happy point between not too much and not too little. Alright, so evidence suggests most blocks are performed at significantly larger doses than are necessary, and we especially want to decrease our dose in those at risk. So less than 6 months, greater than 70 years contribute to about 50% of closed claim cases. In fact, 6 months old patients have a 6-fold higher risk than other children. People with very weak, very sick hearts, we want to really minimize our dose. Local anesthetic plasma levels are determined by block site, intrinsic vasoactivity of local anesthetic. For example, lidocaine is a vasodilatory local anesthetic versus mepivacaine is not, which is why epinephrine and lidocaine improves the duration more than it does in mepivacaine. Use of epi as a marker and cardiac, renal, and hepatic dysfunction. These determine our local anesthetic plasma levels. Believe it or not, body weight does not correlate with local anesthetic plasma levels. And so if you have a 70 kilogram or 110 kilogram male, they both actually have similar plasma levels. And that has to do with volume of distribution, total body water, protein binding, and other factors. Remember that when we aspirate, you may have a 2% false negative rate, or 1 in 50 aspirations may not be accurate. If you do use epinephrine, which I personally do not, but if you do, 15 micrograms or 3 mLs of 1 to 200,000 epinephrine in local, like for example our epidural test dose is 1.5% lidocaine with 1 to 200,000 epinephrine, which is 15 mics. So that 3 cc's, if you see the heart rate go up by 10 or the blood pressure go up by 15, that'd be a positive test dose. Now the data now does show that ultrasound prevents vascular puncture and reduction of local anesthetic systemic toxicity. But I want you to remember that you can be blinded by ultrasound. Make sure you see your target, your needle tip, and your spread, or you're being blinded. There's 40 cases in our literature of symptomatic intravascular injection despite the use of ultrasound. So we want to see that hypoechoic region on the field, and that's not 100% effective because we're moving our needle around, but we want to see that spread to know we're not intravascular. All right, so how do we diagnose toxicity? Well, it's very variable. In fact, atypical presentation is in 4 out of every 10 published cases. Symptoms may be delayed. They may be only cardiovascular. They may be only central nervous system. They may be both. Vigilance is of critical importance. Now, CNS-wise, you may see excitement, agitation, confusion. You may see metallic taste in the mouth, perioral numbness, or ringing in the ears. You may see coma, respiratory arrest, or depression. So let's say you do your block, you gave one a Versed, and all of a sudden the patient's hard to arouse. That's not normal. Something might be going on. That might be your local anesthetic systemic toxicity presentation. A CC or 2 in the vertebral or the carotid, boom, immediate seizure. Cardiac excitation, you may see hypertension, tachycardia, ventricular arrhythmias may develop, but more commonly you'll see bradycardia, systole, and PR interval increases, things along that nature. So you do your block, you look up, the heart rate's 140. Is that last? You do the block, you look up, the heart rate's 40. Is that last? You look up, you see a lot of PVCs. Is that last? Potentially, all these are last. So you grab your intralipid and give it. So remember, only about half the time is pure CNS. The other half is either both or cardiovascular only. And you can see a broad range of CNS symptoms as shown here. Now with your cardiovascular presentation, 16% bradycardia, 1 out of 5 cardiac arrest, 1 out of 3 conduction delay, 1 out of 3 other kinds of arrhythmias. Just of note, 2/3 of cases in the Close Cane project where 2/3 were female, 50% were in extremes of age, and greater than 90% with potent ones. Less than 1 in 5 cases involved continuous infusion, although that's been increasing over the years. And more than 1/3 involved patients with underlying cardiac, neurologic, metabolic disease, for example, diabetes or renal failure. All right, so you do your block in the block room, and 89 seconds later is the mean time to first symptom. But 1 in 5 minutes is very common. And 25% of cases is more than 5 minutes. And it may be as frequent as 1 in 1,000 blocks, you have some level of last. So remember, if you do your block, you can't leave the room and leave the patient alone. They have to be left with a nurse on a monitor, because 5 minutes later, 20 minutes later, they may have, from a partial intravascular injection, they may have toxicity and could seize and have a respiratory event, have cardiac depression. So never do your block and run. Always make sure a patient's on a monitor and someone's in charge. So overall analysis of last. Seizure was the most common presenting symptom. Less than 20% involved classic symptoms. Be ever vigilant at patients of extremes of age, cardiopulmonary, renal, hepatic, metabolic, or neurologic disease, and consider last in a patient with unexplained agitation or CNS depression or signs of cardiovascular compromise. All right, how do we treat last? Patients in front of you, they start seizing. You got to stop that seizure. I don't know if you've ever looked at a blood gas of a patient having a seizure, but it's usually in the high 6s. You have tremendous amount of lactate buildup and drop in pH, as well as hypoxia, hypercarbia. Now remember ionization of local anesthetic. We have local anesthetics, they have a pKa and they're usually high. That means in an acidotic milieu, you will have an ionized form of the molecule. That ionized form will not be able to get out of the myocardium and it will become ion trapped. So you can prevent progression of the toxic hormone by preventing the acidosis. Because as the pH is normal, you have less ionized and less trapped in the myocardium in the brain. So patient seizing, you give a benzodiazepine. Benzodiazepine is not working, blood pressure is okay, maybe a cc or two of propofol, but consider just putting the tube in. Succinylcholine tubes in. Stop the seizure. Ventilate. Get your intralipid and give it. So airway management is of paramount importance. Circulatory is paramount, and promoting the diminution of the effects of local anesthetic is paramount. So seizures should be controlled to prevent injury and acidosis. Benzodiazepines are the ideal drug. We have Versed around. Grab it, give it. We have Valium around. Grab it, give it. We don't frequently have that though. We have Ativan around. Grab it, give it. Stop the seizure. Seizure's not stopping. Put a tube in. Restoration of coronary perfusion pressure is important. So if you have an arrest, you have to give epinephrine. So you start CPR, you give your intralipid, you grab your epinephrine. You do not give 1 milligram. 1 milligram of epinephrine is the ACLS protocol for out-of-hospital cardiac arrest. If you have a plaque rupture in your coronary and you fibrillate, 1 milligram is appropriate. But that's not what's happening here. What's happening here is we have toxicity from a poison. And we have to just get that heart kicking to get that intralipid to circulate. So we'll give 1 mic per kilo. We can give escalating doses, but we want to give 1 mic per kilo. We want to avoid vasopressin. We obviously want to avoid more lidocaine. So it's epinephrine, 1 mic per kilo, CPR, intubation, intralipid. Call the cardiac bypass team. If patient is in refractory arrest, you're not going to call the code. There's cases in the literature of 40 minutes of CPR where patients left the hospital. If everything else fails, repeated doses of intralipid. All else fails, you go to fem-fem bypass until the drug is able to disassociate away from the organs affected. Lipid emulsion can be instrumental in facilitating resuscitation. Rather than acting as a static lipid sink, current research supports the concept that emulsion works as a dynamic carrier to scavenge local anesthetic away from the high blood flow organs that are most sensitive to last, and redistribute it to organs and store it and detoxify the drug in the muscle and liver respectively. Local anesthetic binding to lipid droplets is believed to be from positively charged, fat-soluble local anesthetic molecules bind to negatively charged lipid particles. There's actually a cardiotonic effect to the intralipid, and several lines of evidence support the concept that lipid emulsion increases cardiac contractility, which increases cardiac output and blood flow through the affected organs. And there's even a post-conditioning effect of the intralipid that activates cardioprotective pathways and provides additional mechanism for post-conditioning benefit to the local anesthetic toxic heart. So how do we give intralipid? You grab it and you give it. Used to be 1.5 mLs per kilo, so a 70 kilogram meal would be 100 mLs, but now they're telling you for an adult, just give 100, run it in. Then grab a 2 or 250 bag and run it in over 15 to 20 minutes. Then repeat the bolus of 100, run it in. Consider doubling the bolus, consider doubling the infusion. Now if you have a baby or a child, volume is limiting because there's only so much space inside the baby's body, so you will give 1.5 mLs per kilo. Intralipid's safe. Maybe you'll get a little lipase elevation, but it's not going to kill the patient, so give it even if you're not sure. The old guideline said only give it when everything else fails. The new guideline says give it at any rapidly progressing toxidrome. So if I suspect I have toxicity, I'm giving 100 mLs. I'm grabbing a 250 bag. I'm going to let it run in with the roller clamp, not put it on a pump over 10 to 15, 20 minutes. I'm going to consider repeating the initial bolus, and I'm going to have the ability to double my initial bolus or double my infusion if I need to. We can push all the way to 12 mLs per kilo. If you have toxicity, you may want to consider monitoring the patient. The latest guidelines say at least 6 hours of stability, so 6 hours when everything is normal. But you have to use your clinical judgment if you need more monitoring. Now, Propofol is a 1% drug. That means a 1% drug is 10 milligrams per ml. But it's in a 10% fat emulsion. Remember, there's soybean oil, there's egg lecithin, there's sulfites, there's all kinds of things in propofol, but it's a 10% fat emulsion. So I just told you have to give 100 mLs of 20% fat emulsion. That would mean you'd have to give 200 mLs of Propofol. And since Propofol centrally decreases sympathetic tone, that's not something you want to do as a poison in their heart causing negative inotropy chronotropy. So Propofol is not a substitute for intralipid for the cure. Now, what is intralipid? Intralipid is given as peripheral nutrition. It's very shelf stable. It can stay in the drawer of your anesthesia cart for 2 years. Just look at the expiration date. It's cheap and it's available. But if you're doing a block, you better know where it is so you can get it in the patient as soon as you have presentation of last. All right, it was a pleasure talking to you guys about local anesthetic systemic toxicity. Please refer to the full guideline for more information.